Hello, good afternoon, everyone. So nice to see you all today. Happy New Year and happy Wednesday on this January day. My name is Allison Elsner, and I'm the CEO at the San Bernardino County Medical Society. I'm here with my colleagues, and we are also joined by our esteemed speaker today, whom I will be introducing in just a quick moment. Our session today is titled Medi-Cal Enrollment and Physician Offices, Action Steps so that you don't get left behind. And this is, as many of you know, the second session in our series of 5 total sessions that we are presenting on the entire Medi-Cal process as far as changes that you can all expect, changes that will be coming up with the patient communities and patient communities that you treat, so that you're going to be able to continue as a trusted resource and a guide for your patients to help them. You can continue seeing them, they can continue to get care. So with that, just a couple of quick reminders, please, as we go along, feel free to enter your questions into the chat. Our speaker is very open to taking those questions as she goes along in her presentation. So as you think of them or if she says something, go ahead and put your question into the chat. The more questions, the
Wow.
better, so
Okay.
that we get
I will
some
look for sure. Okay. Thank
discussion
you.
going. And all right, so with that, let's go ahead. And one more quick thing for any of the physicians on the line, we do have CME approval for this. And we want to make sure you know that. So if you attend this session, you will receive 1.25 CME credits, which we want to thank Loma Linda University School of Medicine and Continuing Medical Education Office for. Very, very much appreciate the partnership with them. All right, so our wonderful speaker today is Theresa Hasbrouck. And let me just pull this up here. Theresa has really become our go-to person. As I was telling her, we try not to abuse that contact, but she's become our go-to at the Department of Healthcare Services. Theresa serves as chief of the Policy Development Branch in the Medi-Cal Eligibility Division at Department of Healthcare Services for the state of California. She leads key Medi-Cal eligibility policy areas, including financial eligibility, applications and renewals, immigration, DHCS, Cal, SAWS, SAWS support, and other high-profile topics. Theresa works to build strong partnerships with county medical offices, the statewide automated systems, community-based organizations, and other stakeholders to develop clear, effective policies and resources that help ensure accurate Medi-Cal eligibility determinations. Born and raised in Stanislaus County, Theresa began her public service career in the nonprofit sector, coordinating programs and services for historically marginalized communities. She went on to serve as a Medi-Cal supervisor at the Stanislaus County Community Services Agency before joining the state. For over 20 years, she has been deeply committed to making sure Californians have access to affordable health care, keeping the needs of Medi-Cal members at the center of her work. So with that, we are very honored to have Theresa Hasbrouck with us today. And Theresa, we'll turn it over to you. Please take it away.
I thank you so much, Allison, and good afternoon, everyone. First, I just want to commend all of you and your commitment for being here during the lunch hour. I know the work of physicians and physician organizations is extremely busy, and finding time for things like this can be really challenging. And it just speaks to the commitment that all of you have to really building a healthier California. And we are definitely going to need you all as trusted sources as we move towards some pretty significant changes here in California with our Medi-Cal program. And that's exactly what I will be talking about today, is what changes are coming to Medi-Cal eligibility that is critical for you all to be aware of. One, because it's going to affect, in some instances, whether an individual stays in continued medical coverage with you, and then, secondarily, whether or not just overall folks are able to qualify and continue their medical journey. And so it's really important that we all understand that. One thing that we learned about during the continuous coverage unwinding a couple of years ago is that in our minds at DHCS, we were pretty convinced, we understood that we were a trusted source, that our local county offices were trusted sources, and that's where most people got their information about their Medi-Cal and their coverage. What we learned through a lot of conversations with our members and our different stakeholder organizations is that while we are a trusted source, we are not the trusted source. Folks in the community, particularly those where their medical needs are being met, are really the folks that they turn to and look to for support and understanding and information. And so as we are sort of beginning this year, really educating all of our partners about what is coming for Medi-Cal, we know that our physicians are a critical piece of that puzzle. And often you are the most trusted source that our members are speaking to about their health needs. And sometimes that includes their coverage and whether or not they're still in coverage with Medi-Cal. So thank you so much for being here. And hopefully you find this information helpful. Some of this information is going to be a little bit more complex in eligibility. I'm going to try to simplify it as best as possible, and I'm going to definitely try to relate it to how you can play a role in that. But certainly, please, I'll stop after each section and see what questions are there to help make sure that the information makes sense as we go through. So there really is two big things happening right now that are affecting eligibility for Medi-Cal here in California. One is last year's budget cycle did make several changes to how we are treating Medi-Cal eligibility for certain immigration populations. And so in layman's terms, that means that certain eligibility pieces are going to be a little bit different based on your immigration status than they were before, which means their coverage will look and feel a bit different. So we're going to talk about how those changes are affecting maybe some of the patients that you all are seeing. And then the second thing that we're going to talk about is what we are considering to be sort of the overarching big impact in California. And that is based on the provisions of House Resolution 1. You'll hear me call it HR 1. Some folks refer to it, or it was referred to as the One Big Beautiful Bill, but you will only hear me refer to it as HR 1 as we go through the presentation today. And we'll talk about really what is coming with that and how that will have pretty significant downstream impacts to the Medi-Cal program. So let's start with our state budget changes first. And the first one we're going to talk about is our asset test reinstatement or asset limit reinstatement. So in California, in case you didn't know, there are multiple different ways or methodologies that folks can become eligible to Medi-Cal. When the Affordable Care Act came in 2012 and implemented in 2014, that did away with any sort of asset test for most of the people in California. But for other populations who got their Medi-Cal because they were aged, blind, or disabled, or from some other reasons, they still required an asset test to have access to Medi-Cal. We did actually remove the asset test completely earlier in this last few years. However, during the last state budget, there was a need for us to actually bring that asset test back. So starting January 1st, so just this very past January, what now is required for individuals who have a Medi-Cal program that requires an asset test, and here on the screen is those types of folks that historically have an asset test. I know families with children show up on here. That usually is a very, very small portion of the folks that have an asset test. It is primarily those that are age 65 and older, disabled, blind, or receiving long-term care services that are our main population. In essence, they will now need to submit their asset information, and their assets need to be under a certain limit in order for them to continue to qualify for Medi-Cal. And so assets really are made up of a variety of different things. And so often you'll hear us refer to them as property. And it's really your bank accounts, the land that you own, if you own buildings, those types of things, cars, trucks, any type of thing like that. There are certain pieces that absolutely are excluded and not counted. Like an individual can have a vehicle and we're not going to count that as property. They can own a home that they live in in, and we're not going to count that as property. But if they acquire more than that, then there is a limit to how much property they can actually have. And I think the limit's next. No. So the limit for property for these populations is going to be $130,000 for a single person and $65,000 for each additional person. So what that means is not their income, not the money they get every month, but if they have money in a bank account or they have a second home and those things are more than $130,000, they will no longer be eligible to Medi-Cal. This is true for our individuals that are already on Medi-Cal coverage. And this is also true for folks that are newly applying as of January 1st, 2026. Those that are already in the Medi-Cal program won't need to worry about turning in their property information until their next annual renewal. But at that renewal, you will see that they will begin to be asked about the things that they own in order to keep their Medi-Cal eligibility. And so for whatever reason, if this happens to come up at your office, or people have questions about that particular piece, or why you may see that individuals are not qualifying any longer and able to access Medi-Cal, it could be because they had more property than was allowed by this particular limit that we imposed. We wanted to make sure that our existing members had lots of information about what that change means to them. What you'll hear me talk about throughout is that the most critical piece for myself and my team is that when we implement these changes, that folks understand what is happening to their eligibility and they know what they can do in order to continue in coverage. And so all of our existing members did receive an outreach letter that let them know about this change, and then also provided a tremendous amount of frequently asked questions that answered a lot of things about what they're going to need to do, when they're going to need to do it, and most importantly, what happens if they do have more assets than the amounts that we are sharing with them. And so, the intent was to give folks as much ability as possible to do what they need to do to become within the asset limits for these programs. So before I move on to the next state budget change, which was our adult expansion, I'm just going to check really quick and see if there are any questions in the chat on this particular topic. So the question is, does retirement savings count as assets? And the question is really, it sort of depends. If they are getting income from that asset, so they are actually drawing down a payment from that particular retirement account, then no, it's not counted as an asset because we're actually using the income that they're receiving as income. And fun fact about Medi-Cal, you can't count something for property and income in the same month. It has to be one or the other. Where we would count a retirement account is, for example, if I owned a 501k, 501, I don't even know what they're called now, an IRA account, and I was able to, I'm not getting a payment from it, and I'm able to liquidate that without, I have the ability to do that, even if there's a penalty associated with it, then that retirement count would be counted as an asset. So everybody's situation is very different. Many retirement counts are excluded, and this is a really good time when it gets into those level of questions where connecting them with the local county office is the perfect fit. And I actually believe, I think the speaker after me in the next session or the following one is from the local county office, and that's a perfect partnership to make if there's members that have those level of questions. The next question is the value of secondary real estate the assessed value alone or the net difference between value and mortgage? Very good question, Larry. And so, yes, it is actually the net value. So if I owned a second property that was valued at $200,000 and I owed $190,000 on that home, only 10,000 of it would be used to help determine where I am at from an countable property or asset perspective when it comes to that limit. Really good questions. All right, I'm going to go ahead and move us along to the next topic. And the next two are really around sort of immigration related items. So in California, we had something called various different expansions. And what these adult expansions did is it allowed for California to offer full scope Medi-Cal to anyone, regardless of their immigration status. From a federal landscape, we only receive federal funding for individuals that are considered to have satisfactory immigration statuses. But California made the decision to provide healthcare coverage regardless of that, whether somebody had satisfactory immigration status or unsatisfactory immigration status. This is very limited primarily to those individuals without an immigration status or who never provided verification of their immigration status. And then there are also some very minor temporary non-immigrant visa holders that also were part of these broader expansions. So in January 1st, 2026, we are no longer going to be allowing new individuals to be eligible to full scope Medi-Cal if they meet one of the adult expansion criterias. So, for example, if I am an individual without an immigration status, 2 months ago, I could come in and I could apply for Medi-Cal. And as long as I met all the other income eligibility, I would be eligible to Medi-Cal full scope, meaning everything that I came to you for as my doctor would be covered. Starting January 1st, 2026, now if I was to go into the office and apply, I would only be eligible to emergency services or pregnancy services only. And anything like standard doctor's appointments, prescriptions, non-emergency related treatments, even if they're in the hospital, none of those are covered anymore for these particular individuals. And so this is the purpose of this particular piece. We want to make sure that as we're talking about covering folks, that we are very careful about removing people who are already accessing services. We know and we heard story after story about how individuals who previously hadn't been eligible to be able to seek regular everyday services to get their diabetes medicines, those types of things, were able to finally get themselves in a normal pattern of healthcare coverage, seeing their providers on a regular basis, and getting those necessary treatments. And we want to make sure individuals that were already in that full scope coverage are able to maintain most of their benefits, even though we are making this change to not allowing anybody new to come in. And so individuals that are existing members are going to be able to keep the same exact coverage they have, except they will now not be able to receive full scope dental. Instead, when it comes to their dental care, they will only be entitled to emergency or pregnancy related dental care. But all of the other services that they are used to receiving, their prescriptions, their doctor's visits, x-rays, all of those types of things, members will continue to be able to receive. That will continue as long as they continue being eligible to Medi-Cal. And this is where we really, really need your help as physicians. We understand that you likely will not know the immigration status of the folks that come and receive services from you, nor are we asking you in any way to gather that information. But what is really helpful is when our providers have just general reminders about making sure when folks are on Medi-Cal that they're completing their renewal. You can do this by, having messages on your interactive voice response system reminding your patients with Medi-Cal to do their annual renewals. It can be as simple as having a flyer, and we've got lots of printable materials that you can use on your desk and having, that reminds folks about doing their renewals. And then, certainly the greatest thing possible would even be giving that sort of verbal reminder when they're checking in to see and seek services from you, about having to do a renewal on an annual basis and making sure that they are doing those when those things come to them from the local county office. Because as long as they stay in coverage, these folks are going to continue to receive their services. And that's really the goal, to help people stay in their coverage. There is something that we included called the grace period. And this is really kind of true with most of our Medi-Cal members, and that if they do lose coverage, So let's say, for example, Janice, now I'm going to use your names in the chat too, so you can feel part of this presentation. Janice has a renewal that is due, and she doesn't do the renewal for whatever reason. Janice didn't get it, or she's got stuff going on, and Janice isn't able to complete that renewal on time. And Janice ends up getting discontinued from her Medi-Cal, and her Medi-Cal is terminated. She will have 3 months to come back in and fix whatever the reason she was discontinued for. So if it was for not doing a renewal, she'll be able to turn in that annual renewal. And then as long as she's still eligible, the great news is Janice can go back into the full scope coverage and continue with Medi-Cal. Now, if for whatever reason a member does not come back in within that 3-month grace period, once they reapply, they no longer are going to be eligible to full scope coverage if they don't have an immigration status. And instead, those individuals would revert back to only emergency and restricted scope coverage. So really keeping our existing members in coverage is a critical goal for DHCS and for our county partners. So very similar to the asset test reinstatement, we also made sure that we sent letters directly to the population that was impacted, really stressing the importance of the information I just shared with you, and also providing lots of frequently asked questions. One thing we're hearing a lot of confusion about in the community is that folks that are already on Medi-Cal today, some of them are under the impression that they have already moved to restricted scope coverage. Please know that if they were an existing member prior to January 1st, California is not moving them to restricted scope coverage. They get to keep that full scope coverage as long as they stay in Medi-Cal eligibility. All right, I'm going to check the chat again to see if we have any questions on this one, and then I'll talk about our last state item before I move us into some of the federal changes. So the next question is, this may be addressed later, but how should hospital systems deal with reconciling reduced funding with the federal EMTLA mandatory requirement for them to treat anyone? And so this is an excellent question, Allison, and a little bit outside of the scope of where my expertise is, but certainly a question that I will take back and make sure I distribute to you, Allison, so that you can share it out with this group because it's a good question. All right, I'm going to go ahead, seeing no other questions, I'm going to go ahead and move us into the last state budget change, which is individuals is our premiums. So some of you all may remember when we had healthy families move into our regular Medi-Cal, individuals and children that had higher income limits had to pay a premium in order to receive their Medi-Cal coverage on a monthly basis. A few years ago, California moved away from premiums. And so at this time, there is no program that has any premiums in the state of California for Medi-Cal purposes. However, coming July 1st, 2027, there is going to be a broader population of individuals with unsatisfactory immigration status that will receive a premium. So immigration starts to get very complicated. The first change we talked about was specifically for individuals who did not have an immigration status, who failed to provide their immigration status, or who was on a very temporary visa. They are not federally eligible to Medi-Cal, and they are also, in California's eyes, considered an expanded population from who we typically had provided services to. There is actually a broader umbrella of individuals who have, from a federal lens, have immigration status that does not qualify for federal funding. This is individuals such as legal permanent residents who have not been here yet for 5 years. And there are a few other lawfully present immigrants who just do not qualify for federal funding. For decades, California has provided full scope coverage to those populations with them being lawfully present. And so this is talking about not the small population that we were talking about with the population freeze, but this is talking about any immigration population that does not qualify for federal funding. So that much broader group of individuals beginning July 1st, 2027, who are aged 19 to 59, who are not pregnant, will be required to pay a $30 monthly premium. for this $30 monthly premium, if individuals miss their premium payments for 3 months in a row, they'll continue to be on coverage that entire time. But if they miss it for 3 months and they just do not end up paying, this population will also move to what we call restricted scope, which only qualifies for that emergency and pregnancy services. So just another area in which individuals are going to need to make sure they're taking action in order to continue their full scope coverage. There'll be much more information about this particular change once we get closer to 2027, but wanted to make sure that just for awareness that you all knew that this was on the horizon. All right, so that does make up all of our state budget changes. It doesn't, oh, sorry, I forgot. I have one slide and I'm not going to go into too much detail, but this just kind of, because there's lots of changes, this just kind of talks about which population is actually affected by which particular provision that I just mentioned. And I think this PowerPoint will be shared out. If not, I'll make sure that you all get a copy of this PowerPoint. And so it's good for reference just to understand how all of the things we're talking about affect different people that you might be serving. All right, so let me see if there's any questions, and then I will move us into the last one. Okay, I think we're good on questions. So now I'm going to move us into our changes that's happening based on federal changes. And so there's really, we know there are lots of changes and changes you likely probably want to ask questions about that go outside of the eligibility scope. For today's presentation, because my space is really getting people into the program and protecting the members while they're in the program, that's where my world is sort of shaped by. I know there are pieces that touch on our managed care plan partners and other types of payments. That will be a bit outside of the scope of what I'll be presenting today. And so there are really three big buckets of changes that are coming to California. Some of them impact people's ability to their eligibility, ability to be eligible, but also sort of impacts their ability to even access Medi-Cal from the first place. The three provisions, and we're going to talk about two of these quite a bit, is work requirements, which is coming for the first time in Medi-Cal's history. 6-month eligibility checks for certain populations, changes to how many months somebody can qualify for retroactive Medi-Cal coverage, and something called cost sharing. And this one might be of interest for you all as we talk a little bit more about this in a moment. We talked about quite a few changes happening to our immigrant populations based on some state budget changes. We are also going to be hit with some changes federally to certain pieces in regards to immigrant coverage as well, related to who we can receive federal funding for and how much federal funding we will now receive for those emergency services I was talking about earlier. And then the last sort of bucket that we have to think about is the enrollment integrity and just steps that need to be taken to ensure that people are in Medi-Cal, actually legitimately should be in Medi-Cal. And those are ones that actually there's already great efforts on this, and this really just helps continue to build that great integrity quality that California really strives to be. So let's talk a little bit about timelines. And I've already said these, so I'm not going to go into too much detail. This is a snapshot. Again, when you all have a copy of this presentation, this is a snapshot of when all of these things are taking place in one single slide. When we drill down to sort of each of those eligibility and access and other buckets that I was talking about, you'll see a majority of the items related to eligibility and access are actually going to be happening on January 1st, 2027. The only sort of outliner to that is cost sharing is going to come a bit later, and that's going to be coming in October of 2028. For provisions related to enrollment integrity, those are also going live on January 1st, 2027. And I'm going to talk maybe a little bit more. Actually, I'll go back and talk a little bit more about cost sharing as well, but just a bit more on these two, because I'm not going to go into great detail about them. But in essence, what this is doing is it's allowing us to do two things. One, the one we absolutely love and kind of a carryover from the continuous coverage unwinding, is that we know in order for folks to receive all of this information, their renewal paperwork, everything they need to actually keep their Medi-Cal, we have to have the right address on file. We know that prior to the continuous coverage unwinding, we had a significant amount of addresses that weren't correct. And so folks were getting returned mail constantly, and they never even got the information they needed to renew their coverage. And so during the preparation for the unwinding, we spent a great deal of time partnering with our managed care plans and other trusted sources to really focus on getting folks to update their address information. What this provision does is it allows us to continue to take address updates from our managed care plans and be able to pass those on to the counties and immediately update the case files for those members so that they do not fall through the crack. It also requires us to use the National Change of Address database, which is the number one way to really keep people's addresses up to date. It allows us to and mandates us now to use the NCOA database and to update addresses based on that change alone. This should reduce the amount of folks that we lose contact with simply because they moved and forgot to change their address with us. The other thing this does is just requires us to do some data matching with the Social Security office to remove people when they pass away, for us to remove people when they pass away. This is something we're already doing, and so this is not a change for California. The last piece is in October 1st of 2029, our federal partners are going to be creating some sort of massive database to help keep track when folks leave the state so that we can ensure that that information is updated and provided to us timely so that we can take appropriate action if they're no longer eligible. So those are sort of the changes that are happening in regards to enrollment integrity. I'm going to take a step back for just a second and talk a moment about two of the ones on this slide because I'm not going to go over them in greater detail after we're done here. And that's really around retroactive coverage and also co-payments. I'm going to introduce to you all about a very specific group of people. And the reason I'm going to introduce you to this group of people is because you are going to hear me talk about these particular Medi-Cal members over and over as we talk about the federal changes, because they are primarily focused at this group. So for those of you that are familiar with the Affordable Care Act, we had the opportunity in California to expand our Medi-Cal program. Before, to get Medi-Cal, you had to meet a certain criteria. You had to be age blind or disabled. You had to be a parent. You had to be a child. You had to be pregnant. And if you didn't meet one of those criterias, you could not get Medi-Cal. So we often refer to it as the MAGI New Adult Group, or the Modified Adjusted Gross Income New Adult Group, or Adult Expanded Group. And these were individuals that, because of the Affordable Care Act, that were aged 19 to 64, for the first time might have been eligible to actually have Medi-Cal coverage, because before they did not have a link to coverage before. Because that particular group has a higher income limit than our previous Medi-Cal programs, even though the intent was really for adults who weren't linked before to have coverage, we also know that it expanded and allowed parents that had higher income to also enter that group because the income limit was higher. And so this group, you will hear me call it throughout the rest of the session, is our MAGI New Adult Group. Modified Adjusted Gross Income, which is the methodology that came with the Affordable Care Act. For short, we call it MAGI, the MAGI New Adult Group. When we're talking about the provisions that we're going to be talking about today, it does not apply to everyone on Medi-Cal. It only applies to the MAGI New Adult Group when we start talking about some of these provisions. And so you'll hear me use that term, so I wanted to explain it. So the first one I'm going to talk about just in this slide is the retroactive coverage. Today, people can incur some sort of medical bill. So they had an emergency, they went to the hospital, they were seen, they didn't have any medical coverage. 2 months later, they are getting medical bills and decide to apply for Medi-Cal. They can ask Medi-Cal to go back for up to 3 months to pay medical bills that they incurred during that time period. And as long as they're eligible, Medi-Cal will cover those costs. Coming January 1st, this is being restricted. That Magi New Adult group now only is allowed 1 month of retroactive Medi-Cal, and everyone else that applies for Medi-Cal is eligible to 2 months of retroactive Medi-Cal. And so if any of you all are physicians in a hospital setting or have good partnerships with hospitals, or even see patients while they are waiting for insurance, or seeing uninsured patients, and you later help get them connected with Medi-Cal, it's really, really important to understand their window of being able to get those things covered has been shortened drastically. And so it's very important to make sure that if folks are uninsured, that they get coverage right away, so that they can apply for those retroactive months. The other thing that I alluded to earlier is we have not had co-payments in California for a couple of years now. Before, we did have $1 co-payment for many of the services we offered. California elected to get rid of that. However, HR 1 does require states to do this. The positive thing about it is it does allow us to, we have the ability to determine which services receive a copayment and how much that copayment is. And so that is something that we are actively making updates to in the governor's budget right now. We're, of course, attempting to mitigate this as much as possible. But what this could mean is that you might see certain services in the future have $1 copayment associated with it that you may choose to collect in order for somebody to receive services, but only for certain services, and much more information to come. But I think this one really has sort of a direct impact on the work you do day to day. I'm going to go over one more thing, and then I'm going to stop for a moment and just see if we've got questions before we dive into the big two, which is our work requirements and our 6-month eligibility checks. But the last two I just want to sort of mention is that we've got things related to immigration. Today, California receives federal funding at a 90-10 split, meaning for every dollar we spend, if we are administering emergency or pregnancy related services to the restricted scope population, we get 90 cents back and the state puts in 10 cents. Come October 1st, 2026, this has been changed to now be 50-50, meaning we have to put in 50 cents and the federal government will now put in 50 cents. And so, as you can imagine, this is adding significant cost to states to administer this particular program. Additionally, what is happening in October 1st of 2026 is that there were other individuals that before HR 1 were considered to be qualified non-citizens. They were eligible to federal funding. This included our refugees, our asylees, our battered immigrants. That population was always eligible to federal funding. HR 1 redefined who actually constitute a qualified non-citizen, and this population is no longer included in that definition. And so what that means is those individuals will not be eligible to federally funded full scope coverage. And so, again, this is one that is currently going through the governor's budget, and more information about how these particular things evolve definitely for the future. So before I dive into our last few topics, I just want to pause and see if there's any quick questions on any of those that I went into a little bit more detail about. All right. Not seeing any questions. I'm going to go through. There's some stuff that gets really into the weeds. I'm going to talk about it very high level, but I want to be respectful to that this may be too detailed for this particular audience, but I want you to have those resources should you need them. One of the biggest things that's going to be impacting our Medi-Cal members, and again, this is only our Magi New Adult group, is work and community engagement requirements. And this will take effect on January 1st, 2027, and it's targeted at adults ages 19 to 64. And what this does is it requires adults in the Magi New Adult group to participate in work or community engagement activities for at least 80 hours per month in these types of activities. There's lots of different ways that individuals are able to meet the requirement, and we'll talk about that in much more detail. But the obvious ones are, of course, if an individual is working at least 80 hours, they meet the requirement. If their federal minimum wage, so 80 hours times federal minimum wage, if their gross monthly income equals that amount, and right now that amount's $580, they're considered meeting the work requirement. If they're attending school at least half time, if they're participating in any sort of work program or doing community service or volunteering, any of those kind of things, that would constitute them meeting the work requirement. Individuals will need to meet the work requirement at application time in order for them to be eligible for Medi-Cal coverage. And that's the big piece I think is really important for our partners to begin to understand is if somebody does not meet the work requirement and applies for Medi-Cal coverage, they and are part of the Magi New Adult group, they may not be eligible to Medi-Cal at all based on this new requirement. There's different rules, of course, for our existing members. There'll be transitions and those types of things, but it's really important to see how this will impact the Medi-Cal application process in the future. We did issue some guidance out there in the community already. In case you all don't know, we issue something called All County Welfare Directors Letters. And that's really just policy guidance that talks about the ins and outs of how California will be administering this particular requirement. So if you are a policy person or just are interested to hear more about how this will be, that's a really great resource to use. The next slides is where we start to get a bit into the weeds, and I'm not going to read line by line, or you all will never let me come back and speak. But just to say, we know that there are some folks that are not going to be able to participate in work and community engagement requirements, even though they're part of that new adult population. And so the federal law does allow for certain exemptions, and all of those exemptions are listed here. And so if individuals meet an exemption, it means they do not need to meet the requirement that I just talked about. When we say mandatory exemptions, these are ones that we have to, by federal law, provide in California. There's quite a few. There's even a second page to all of the exemptions. So the good news is there's lots of ways in which people can be exempted from these work requirements. But there's also optional temporary exemptions. And these are ones that states have to raise their hand and request that we do this particular piece. And so just to share with you, DHCS will be moving forward with these optional exemptions. Probably the most important one is that if there are counties with high unemployment rates that's either above either the lesser of one of these two, 8% or 150% of the national unemployment rate, which is currently 4.2%, they also that whole county can be exempted from work requirements. And so currently there's 22 counties that are exempted, and there's just a few counties that are listed there that are part of that exemption. So really just sharing for you all that there are going to be some counties that automatically will not have to participate. Unfortunately, at this time, it does not appear that San Bernardino County is one of those counties, but this will ebb and flow over time as counties move in and out of the criteria for unemployment. There's some other ones on here as well, but I think the big ticket item is definitely the high unemployment rate. We also know on the southern side of California, we are often impacted by natural disasters. Particularly, we have had very hard wildfire seasons. This also allows us to exempt folks when we are facing federally declared emergencies or natural disasters within the state. And so just want to make sure that we share that information as well. So, one of the provisions of work requirements is that states actually have to do everything possible to use different data sources and information that's already available to try and exclude or exempt people from work requirements before we even ask them to do anything. And so, where we have been focusing our efforts for this beginning phase is really figuring out, however possible, we may be able to gather verification that folks meet this exemption. This is another space where our physician partners, unbeknownst to you, will be really critical partners, because part of what we'll be using for an exemption, hopefully, is going to be claims data, and using the data where you make claims based on services they received that can tell us whether somebody meets the medically frail definition and an automatic exemption. And so, just to give you an idea of what we're doing, we're basically taking these steps to try and verify with individuals to make this process as easy as possible. We're very, very focused on making sure we continue with Medi-Cal members, continuing in this. We know that this will impact, close to 4.8 million people. We know that there is a huge chance, if we do not exempt people and they are not already meeting the work requirement, that we are going to lose people. And soon, Michelle Boss, our director, will be talking about what that coverage loss really looks like. And so we're trying to do our very best to make sure that people stay in coverage. So the way we're going to be doing that is through sort of this 5-step process. We're going to assess if individuals meet an exemption based on just their category group or the information having to do with how they're eligible to Medi-Cal. We're going to see if they meet any of the hardship exemptions, like they're part of those counties that we talked about earlier. We're going to see if we've got any data or information or claims records that allows us to exempt them automatically based on that. We are going to conduct data verification, and different activities to try to verify if they are actually meeting the work requirement, if we can't find any exemptions. And then as a very last resort, we'll be requesting information from our members. But the hope is that we can use all the information we have to comply with this provision without the member having to do anything extra. And so this really goes into deep detail about this. I'm not going to go over every piece of that. Like I said, if you are interested in that, Michelle Boss will be doing a very detailed walkthrough of this in an upcoming presentation, and I'll share that with Allison so that you have access to that when it becomes available. But in essence, the first thing that we're going to be doing is we are just going to take a look at how they answered the questions and what they are eligible to, and we will exempt people simply because they don't fall within the category that we're required to meet a work requirement. So that's just simple, normal application questions, and their basic eligibility determination right off the bat may exclude them from having to participate in these particular work requirements. If we still can't exempt them, the system's going to keep on checking. And this is all before real time that this is going to happen within the computer system. So if any of you are familiar with applying for Medi-Cal on our coveredcalifornia.com portal, you know that at the end of it, they get an eligibility determination. So all of these reviews are happening real time behind the scenes so that by the time they get to the end of the application, the system will already know if we had something to verify and confirm their worker community engagement requirement or exemption. So we're going to look and see if they meet any of a hardship exemption. Are they one of the county zip codes that we've programmed in that is currently under a federally declared emergency? Are they in one of the counties that we have determined has a high unemployment rate? And if that's the case, they will be automatically excluded from work and community engagement requirements. The next thing we'll do is we're going to add some additional questions on our applications, and we're going to try to see, do folks meet any of the exemptions that I included in earlier slides? And we're going to see if there's enough information, either how they answered the questions within the application, or even if we have information in our system that says they meet any of these criterias, we will use it and we will also automatically exempt them from the program. And so the goal again is auto exemption whenever possible. And then, oh, sorry, it looks like sorry, you guys are all seeing a preview. I left a little bit of one of the numbers in and forgot to remove it. But in our next step, we're going to look at looking at actually conducting data verifications to see, are people already meeting it? And so just kind of spoiler alert, it looks like about between all of the different steps that we talked about, between checking to see if they have the hours, the income, the employment, any of the exemptions, of the population of that roughly 4.8 million people that are going to need to comply with work requirements, there's about 1.8 million people that we know today that we've got the information to exclude, exempt, or confirm as being met, which is huge. We want to, of course, get that number up. And so we're going to continue to work with all of you. And as we continue to partner with our managed care plans, there might be opportunities, especially when we talk about claiming and those types of things, where you all may, as physicians, play an important role in that place too. And then, like I said before, the last one is really about compliance. This is just talking through some of the data sources that we're going to use. Again, I'm not going to go through this in detail, but just if you are curious at all how we might be accomplishing all of that data look through, this just gives you a really good idea of what we are planning to do to pool some of those data and how we are leveraging some of our programs that we work with and all of those to actually be able to accomplish this. How we're using claiming data, all of those things. This really outlines our ability to do that particular piece. So that might be something you all actually have some great interest in just reviewing and having awareness on. So before I move into 6-month renewals, I know we're getting close to our time soon. I'm going to just check and see if there's any questions in the chat. And yes, absolutely. I see there's a question about sharing when Michelle Boss's presentation will be. I believe it's going to be a recorded presentation. And so as soon as it is available, I will broadly share it out with you, Allison, to share with this group, because I think you're going to really get to see some numbers, which I know some of you are very interested in hearing about. So we'll definitely make sure that you get that out. And Allison, I think I have until 1:30, but please shake your head no if that is inaccurate.
Actually, you've got until 1:15.
1:15. Okay, that's perfect.
Yeah, if that works.
That works perfect. Thank you so much.
Cool, of course.
Okay, just a few more slides. I know this is a lot of content, so thank you all for hanging with me. I'm going to just briefly go over our 6-month renewal, and then we really are in the home stretch. So the other thing that's happening with that same group, that Magi New Adult group, is that right now people only renew their Medi-Cal once a year. We already know that people get discontinued because they don't do their renewal packet. This population is now not only going to have to do a work requirement, but they are also going to have to renew their benefits every 6 months. And so this is going to just create more opportunities for us to have members fall through the cracks. So like I mentioned earlier, your partnership about reminding people to renew their coverage will be so critical, because we don't want to lose people simply because they did not turn in paperwork. It doesn't help us keep people into their medical home. So, for those of you that really are grounded in our process, you know that we try as best as possible to do everything electronically and verify them without even having to send out a packet. We're adding in some new income verification sources to hopefully mean that even though they have to renew, they may not actually have to complete a packet. We may be able to do a lot of that behind the scenes for them. But in instances where we can't do that, they will actually have to complete a packet. We did do quite a bit of work on our Medi-Cal renewal packet to add some things in we think will help reduce churn, to make it more simplified, to reduce the size. Just really thoughtful work as quick as we could, in the hopes that having a shorter renewal packet would mean there'd be a better chance of people not becoming confused and being able to complete it and turn it back in. There are a few populations that are, of course, excluded from this. Our tribal members are not subject to this, even if they're in that particular coverage group. And similarly, our individuals that are in that coverage group, but that are pregnant or 12 months postpartum, will also not be subject to the additional renewals as well. And of course, anybody that doesn't renew today because they are a deemed baby and was just born, or because they're incarcerated, that's not going to change. They still will not need to do renewals. And very similar to the work requirements, we also issued some deeper policy on that. And so if there's any interest in seeing that, there is a link for you to be able to click that in the presentation. All right, I'm going to check for any chats. Um, Okay, perfect. I'm just going to leave that one alone in there. It doesn't look like there's any questions coming up. So for the implementation plan and engagement, we do want to make sure that we've got a comprehensive plan. So you've gotten to hear me say all these things verbally, but we really need a blueprint, just like we did with the unwinding, for everyone to understand where is California going, how do you play a role in this, and how do our other stakeholders play a role so that we all together know how to navigate Californians through these significant changes. That is going to be coming out very, very soon at the end of January, beginning of February. We will be doing an all comers webinar, which means anybody that wants to hear about our plan, please come and come and listen to it. And we will pass along that event and that registration to the Allison. So if that's something you're interested in, you can absolutely be able to receive the information about that. We also have quite a few ongoing work groups with county managed care plans, advocates, community partners. I know that many of you might have excellent relationships with your managed care plans. And so if there are things that you want to lift up to the department, please feel free to do that through your managed care plan. They have been a phenomenal voice for you, for our members, and we want to make sure, that sort of continues. So ideas, suggestions, you can, definitely put them through that. But also, anytime, my email box is literally always open. If you've got thoughts or ideas, innovations on how you think we can make sure that we keep Californians healthy, send my way, and I will literally explore any idea that comes our way to make sure this implementation's as seamless as it can be. We're sharing out lots of regular updates in our various different stakeholder forums. And then, of course, we've got an inbox where folks can send in questions at any time, and we are happy to answer any of those questions. We've got some guiding principles that just, I think, really ground us in what we learned from the continuous coverage unwinding, which is we know the best way to keep people in coverage is making sure that we have systems that automate that process and make it as easy as possible. We've really matured our relationships in our system development, and our system partners are so innovative in the way they are approaching this work. And we are hoping together we will have lots of great solutions to keep people in coverage. That we need to communicate with clarity and connection. And part of that is making sure that when we develop outreach materials, that they are clear to the people we are trying to serve. And those same outreach messages and flyers and print and guidance gets passed along to everybody that touches our Medi-Cal members. That we simplify the renewal experience to make it as seamless as possible, whether somebody goes online or whether they complete the packet through the mail, that process is as easy and simple as possible. And this one is probably the one that's closest to my heart. That we educate and train those that serve Medi-Cal members. And, that's part of why I'm here today. I know this is probably a lot of information. Some of it is good to know, but I think most importantly, you are such a pillar part of our members' journey. And so making sure that you know what is happening to them helps ensure that as many people as possible know what is happening and have accurate information about these particular changes. And then provide timely and transparent communications to members. We know we don't always have control over some of the provisions that are coming down federally that we have to administer on Californians. But what we do have control and care over is making sure that we do the best job that we can to get messages out to our members that make sense so they understand what's happening with them and they understand how they can continue in coverage. And so that's a really important part of our job together. We are looking to do a bunch of different phased in outreach and communication strategies to make sure that materials, resources, flyers. I mentioned earlier having flyers in your office and having those available for folks to grab. Even creating a poster to hang in your lobby. Any of those kind of things are things that we're going to develop some materials for, and that you will be able to access, hopefully to be able to use and leverage to inform folks that might have Medi-Cal in your care. And then last, the most important thing I'm going to leave you with today, and I hope everyone on this call goes and signs up to be a DHCS coverage ambassador. During the continuous coverage unwinding, we gained over 8,000 individuals and entities in California who were connected to DHCS and the messages that we gave that allowed us to have consistent messages across the state about what was happening to our Medi-Cal members. Because of that, California had a record number of individuals that were able to maintain and continue their coverage after the unwinding was complete. And we were seen nationally as the top performers because of the work we did together. We desperately need your help again to make sure those same successes occur as we're beginning to bring in these provisions. Our ambassadors, it's not a paid position. There's no obligations to do anything. You don't have to sign up. It doesn't make you do anything. All it does is it says that, hey, I want to be a trusted messenger. I want to get the information. So if I need to educate the Medi-Cal members I'm working with or new people that are asking me about Medi-Cal, I've got the most up-to-date information to do that. We know that we want to make sure that our ambassadors reflect the community we serve, and to have that diversity, we need so many different entities and organizations to really connect with our diverse California. And that, the messages that come from local folks are where it really matters. And so making sure there are places where members can connect and get information at the local level. The thing that happens most with the ambassadors is you get all the up-to-date information. When we have outreach materials, you get those. When we have webinars on various different things, that information is sent directly to you to be able to sign up and be part of it. It's really just keeping you in the communication link and attending presentations that talk about things that are happening with Medi-Cal members. So really, really encourage you to do that. You may be asking yourself, how do I accomplish this? And don't worry, I've got those links in there. And again, as Allison passes or shares this PowerPoint with you, those are hyperlinked so that you can go ahead and sign yourself up. I promise we are very careful about how many messages you receive. You will not be spammed by the DHCS coverage ambassador inbox, but you will receive some really, really important information. And you can check out the page. There's already great materials on there, including reminders about renewals. And so there may be materials that you can pull from today to help support some of the messaging that I talked about during this presentation. And with that, that does conclude my speaking part of this presentation. Thank you all so much for staying with me during this experience. I'm going to just check the chat and make sure that I didn't miss any questions along the way. It doesn't look like it, but I am also open if you want to raise your hand and have any questions. I'm happy to entertain any verbal questions also.
Wow, Theresa, that was absolutely phenomenal. So clear. You did a really nice job of making it comprehensive, but it was just detailed enough. And I think if there are any areas that people want to delve into further, they certainly know how to do that and can reach out or look on your website. I would think that people should have somebody from their office sign up to be an ambassador so that you get some of that preview information. I know I certainly am going to. So thank you for that. It looks like Alexis may have is your hand up, Alexis, for a question?
No, I just really wanted to express my gratitude and appreciation for all of the incredible information you provided today. Coming from a policy whiz myself, you made me so very happy, Theresa. So thank you so very much for providing all that incredible information.
Yeah, absolutely. Thanks so much, Alexis. And thank you all again for attending today. I know how valuable your time is, and not just attending today, the work you do in our communities and the Medi-Cal members you serve is life-saving. And it is hard times, and I appreciate that we are in this with so many phenomenal people who are serving and making sure that we're keeping California healthy. So thank you all for the work that you do. And if at any time you have any questions, please don't hesitate to reach out to the department.
Well, thank you again, Theresa. And thank you all for being here. We hope you guys will join us next month. We have our next session coming up on February 18th with Sandra Bolin. As Theresa referenced, we do have county people, experts who will be speaking to us. So Sandra is with the County of Riverside, Department of Public Social Services. And then in March, we have Janice Rocco with the California Medical Association on legislative updates. And March 25th, we'll have James Lacurta with San Bernardino County Transitional Assistance Department. So we do have a nice array of speakers that can dovetail with what Ms. Hasbrouck has spoken to you about today. And I just want to see one last call here for any other questions or comments. We are looking, this is your chance, folks, since you have the expert on the line here, but I'm not seeing any hands raised. So, all right, with that, we will be sending out the recording and the PowerPoint as well as CME instructions, and we will see you next month. So thank you all very much. Theresa, thank you again. Great job. Round of applause. We'll talk to you all real soon. Thanks, everybody. Bye-bye.